So, chapter 3, we are going to talk obstetrics. Yesterday we did gynecologic emergencies, and today we are going to talk about delivering babies. We will briefly go over some anatomy and physiology here of the obstetric patient, and from there we're going to talk normal child delivery. We'll talk some pre and post delivery or some actual delivery type emergencies, and then I'll let you guys in on the secret of we're going to talk about all this crazy stuff and all of the things that can go wrong. And then I'm going to tell you that most of the time, delivering a baby sort of just happens on its own. Most deliveries are just inherently normal. The thing that we really beat up during this lecture and the thing that we'll talk about a lot is we need to be prepared for really what could go wrong just in the event that it does, because we really at that point have two patients, and it would be a much better day if we could provide great care for both of them and make it so that everybody gets to have a good day. We went over all this yesterday, talking about the actual organs of reproduction inside of our female patient. The ovaries release an ovum every I would say probably, if you count it backwards, probably still about every 28 days. It happens about 2 weeks prior to your female patient's regular menstrual period, and that ovum goes from the ovary into the fallopian tubes and down into the uterus, where it is either fertilized and implanted, or it is shed along with the uterine lining through the cervix, and normal monthly period and normal cycle just continues to roll. The cervix is the bottommost portion of the uterus. It is what seals the uterus off and keeps it a closed internal hollow organ. The vagina, also, we'll talk about it as the birth canal when we get to the next picture, and you'll see the baby on the inside. Baby is going to grow inside that hollow muscular structure called the uterus, and it's going to grow and develop. The uterus will continue to stretch to accommodate that baby, and from there, when it is time for this baby to be born, the cervix will actually dilate and begin to open and thin out. That cervix is a muscular organ that is generally closed to the outside. The baby, where it is attached to the uterine wall, is the placenta. The placenta in the umbilical cord are what is responsible for supplying all the oxygen and oxygenated blood and nutrients to this baby while it is in utero, growing and developing. When there are problems with the placenta or problems with the umbilical cord, we will see sometimes some pretty obvious to figure out medical conditions with mom, and other times if there is a problem with the umbilical cord in utero, it's one of those things that sometimes they find on ultrasound, and generally is of a dire emergency to the baby, because without that umbilical cord being nice and attached to the placenta, and the placenta being attached to the uterine wall, that baby is not getting any of the things that it needs. So the female menstrual cycle lasts from anywhere 24 to 35 days. The average is 28. The first day of the menstrual cycle begins with menstruation. The endometrial tissue inside of the uterus begins to slough off and become prepared actually for a fertilized ovum. If that hasn't happened, it will just continue to slough, and generally they say about 60 to 80 mLs of blood over 3 to 5 days is passed, and that will encompass all of the tissue and all of the embryo-like material that hasn't been fertilized. Then on the 14th day of the cycle, ovulation occurs again. Another egg is released from the ovary, passes through the fallopian tubes, and the cycle just continues like that. with, again, the average being 28 days and the egg being released every 14 on the 14th day, so 2 weeks prior to the menstrual period beginning again. Now we're going to talk some stages of pregnancy here. We have the pre-embryonic stage. Generally, that is the first 14 days after conception. After that 14th day, the baby turns into an embryo. The embryo is when now the cells are splitting and dividing and start beginning to create that baby from day 15 through the 8th week of pregnancy. The fetal stage actually begins at week 8 and ends with the delivery of a newborn. The technical medical term for a newborn is a neonate. And gestational age. Gestational age is the age of the fetus in weeks from time of fertilization. When we speak in reference to how far along someone is, 36 week is 36 weeks of pregnancy. That's what doctors and nurses are looking for from us when they ask us what is the gestational age. It's really just attributed to the amount of growth and development that this baby has had on the inside. When we speak in terms of a full-term pregnancy, we are talking 280 days, roughly equivalent to 40 weeks. Each period of the pregnancy is broken down into trimesters. Those trimesters are, the first is 1 to 3 months, the second is 4 through 6, and then the third trimester right up into delivery is months 7 through 9. Most of the time, if we're going to see an emergency with a pregnant patient, those emergencies generally tend to happen during the first and third trimesters. So we've talked about the baby growing and developing a little bit, and now we're going to talk about some of the growing and developing and changing that goes on with mom as that baby is growing inside. So obviously, the uterus is not baby-sized all the time. As that baby begins to grow, the uterus will actually increase in size. It becomes much more vascular. It actually will contain just under 20% of mom's total circulating blood volume. A mucus plug will form in the cervix to protect the fetus from any external things getting in there, like infectious processes. It really just sort of double reinforces the cervix and keeps anything that is not meant to be in there out. Another thing that'll go on with mom's reproductive system is breasts will begin to enlarge in preparation for lactation. From there, we'll move on to our respiratory system. Mom's respiratory system is going to significantly bear the brunt of some of this, respiratory and cardiovascular. Mom's oxygen demand goes up by about 20%. And the actual resistance inside of her respiratory tract, because of some of the hormones that have been released, goes down. So she will actually increase in her tidal volume of lung space by about 40%. That means 40% more oxygen is coming in and available with every single breath while mom is pregnant and growing and developing this baby. Moving on to our cardiovascular system. Cardiovascular wise, just like respiratory, everything increases. Cardiac output for mom in pregnancy goes up by about 45%, so almost half. You can expect mom's heart rate to be 10 to 15 beats per minute faster. Her blood pressure should actually go down some during the first and second trimesters. We expect a little bit lower of a blood pressure. A lot of that is just based on same hormones that smooth things out for mom's breathing are also going to decrease her systolic and diastolic blood pressure some. Gastrointestinal wise, We're going to have some nausea and vomiting generally during the first trimester is when those complaints are biggest. There will be some bloating and constipation occurring throughout pregnancy. A couple of the things that we'll come to realize here is as that baby is growing and developing, it is very demanding on all of mom in order for this to happen. So blood will begin to sort of shunt away from places that aren't quite as important. And the GI tract is one of those places. It will sort of subsist on a limited amount of circulating volume down there in order to make sure that the uterus and the baby are receiving enough of the oxygenated blood supply. Add to that, you can look just from this picture and you'll see that the baby is compressing on some of that GI tract and some of the lower structures of mom's gastrointestinal system. And it really kind of stands to reason that using the rest facilities becomes a bit more difficult the bigger this baby gets. If we look at the picture even some more, we'll get into the urinary system. Well, look at where that baby's head is positioned. It is squeezing on that urinary bladder, so it is going to be smaller. It is going to be more urgent when mom feels the need to go to the bathroom, and there may be next to no urine in there, but she's going to feel the need to use the bathroom. The bladder is displaced and can be at a much more risk of injury. And urinary frequency is going to be probably another one of our bigger medical complaints for a patient who is pregnant. In preparation for delivery of this baby, we actually start to see some changes in mom's musculoskeletal system as well. The pelvic joints will begin to loosen as a result of all these hormone changes. Mom will actually have a change in the center of her gravity because of where the uterus sits and it's pulling her forward. The patient will often experience some lower back pain, and sort of when you've ever seen or known someone who was, 8-9 months pregnant, they have a particular walk about them. You can actually tell that they are getting close to time to delivery because their pelvic joints, their hip joints are starting to loosen up. They're experiencing those musculoskeletal problems or changes, and things are getting ready to go live. First thing we're going to talk about is antepartum, pre-delivery type emergencies. I mentioned this yesterday, and we'll talk about it again briefly today, but what is the common term for this right here, a spontaneous abortion? Somebody tell me.
Miscarriage.
Yeah, it's a miscarriage. The book definition, spontaneous abortion occurs when the products of conception are expelled prior to viability of the fetus. So this is a baby who has not grown and developed yet to the point of being viable outside of where it's supposed to be growing and developing, and is for one reason or another being expelled from the body. Sometimes this is just a product of something happened during the development and the embryonic stages and all of that stuff. And sometimes it's just a product of natural selection. They never really can give a good concrete answer as to why this has happened. One of the things that we'll be called for is there's going to be some bleeding and some passing of tissue depending on how far along this pregnancy is. It is generally one of the first trimester emergencies. It is something that we'll see that where mom just started bleeding spontaneously and is beginning to pass things like tissue and uterine lining. And really, there is not a whole long ton of things that we can do about this. Our care, unless there is like very, very significant bleeding, heavy, just uncontrollable bleeding, is mostly going to be supportive. It is definitely going to be, taking good care of mom, because this is mentally a very traumatic, very trying, troubling thing. It happens in about 15 to 20% of all recognized pregnancies. Generally, it does have a genetic cause. Any cramping and vaginal bleeding are usually present like 8 to 12 weeks of gestation. So this would be probably right around the time that shortly after mom realized she was pregnant and getting to the point where, follow up and a lot of that stuff was beginning to be done. And I'll tell you, it's like a switch gets flicked. You go from being, hey, we're having a baby, really, really happy, to, wow, everything about this sucks. Patient history is going to be really important for us. Ask the patient some uncomfortable questions. Ask them about having any cramping. Were they having any bleeding? Are they not, are you sure you're pregnant? But it's important to not sort of just chalk this up to being a heavy period, especially if the patient is rock solid, absolutely sure that they are pregnant. In patients that have had children before, the cramp-like pain that we're talking about is actually similar to labor. So this is something that they'll be familiar with, and they are very likely to tell you it is quite abnormal for where they're at. Next, we have placenta previa. Placenta previa happens when the placenta actually forms over the opening to the cervix. We will have the placenta attach and begin to form and sort of close off that cervical opening. This is going to be a problem come delivery. This is oftentimes associated with painless vaginal bleeding. It'll happen in the third trimester a lot as the baby's beginning to grow and put some pressure on that placenta. Uterus is normally soft and non-tender on palpation. We may see bright or dark blood. It may be an intermediate color. There may be nothing that you can really put your finger on that makes this very, very odd to you, other than you'll see almost a fully developed pregnant belly and painless vaginal bleeding. Our emergency medical care is going to be monitor and treat for signs and symptoms of shock, because this is an uncontrolled hemorrhage and it can be quite significant. Some of the things that'll predispose mom for this are rapid fire pregnancies. So babies that are very close together in age, more than 2 deliveries. So if mom has had a lot of kids, a patient over the age of 35, and history. Has this happened to you before? If the answer to that is yes, and you have a third trimester pregnancy that has come with this painless abdominal bleeding with a soft, non-tender abdominal cavity and uterus, treat for signs and symptoms of shock. We're better off. This baby will not be delivered naturally. This will not be a vaginal delivery. This is a situation where, first and foremost, prenatal care being what it is, most of the time people know about this already and they schedule their C-section. So you probably are very likely to have a very aware patient, a patient who's very up to speed on what's going on, and they may even tell you what's going on. So if your patient has something to say, absolutely listen to them, especially in a situation like this. Our treatment for shock doesn't change except for one part. Think all the way back to CPR and when we were doing compressions on a pregnant or gravid female. What was something that they wanted us to try and do? Does anybody remember?
Avoid pushing on the abdomen.
So yeah, we don't want to go beating baby up before it comes out where it's already having a hard time. Do you remember we had to try and displace that gravid belly? We had to move the belly as much as we could to allow blood flow. So generally when we talk about shock, we talk about laying our patient flat, keeping them warm, and oxygenating. With this patient, we are going to oxygenate. We do want to keep them warm because this is definitely one of those times we should be concerned for hypovolemic shock. But we don't lay pregnant females flat on their back like that because we can cause some pretty significant hypotension and accidentally cause some obstructive shock by limiting blood flow returning to the heart by allowing baby to compress on the inferior vena cava. What we really want to do is wedge them up so that they lay on their left side. Gravity will pull baby down towards the stretcher and towards mom's left side so that now she is able to circulate her blood volume and thus oxygenate and provide oxygenated blood to both her and the fetus. You do that by just wedging a pillow or something underneath your patient's right hip, and it will pop them right up onto their left side, and you can secure them right as rain onto the stretcher, and everything will be okay. Next, we are going to talk about an abruptio placenta or placenta abruption. This is a large-scale problem all around. There are two different types. We have a complete abruption or a partial. In a complete abruption, the placenta has completely torn away from that uterine wall. So what do you think that means for baby?
Not getting any more oxygenated blood.
Yeah, not getting any more anything. Complete abruptions generally have a 100% fetal mortality rate. Partial, we have a bit better of a mortality rate with that because some of that placenta may still be attached to the uterine wall and supplying baby with what it needs. It's about a 30 to 60% mortality rate. And this is going to have problems with blood loss as well. We're talking severe maternal blood loss. Remember that uterus becomes more vascular in order to support this growing person inside. We will see constant abdominal pain a lot of time with this abruption. We have sometimes lower back pain. We'll have some uterine contractions generally present. Again, the bleeding can be just about any type or color, but we're talking generally, concern for shock here, hypovolemic shock, because when that placenta comes away, even during a normal delivery, we expect some blood loss. There is some bleeding that goes along with delivering a baby. What we can't have is just whole-scale damage to the uterus and uncontrollable bleeding, because facts being facts, mom needs that blood. If mom bleeds out, baby bleeds out too. So we're definitely dealing with some pretty significant issues here, and our assessment's going to be key. We need to get to the bottom of how much bleeding has happened. What does mom present like? Because the best care we can provide to a baby that is in utero and still on the inside is to provide good care for mom and get her to the emergency room in as good a shape as possible. Some things that'll be predisposing factors for a placenta abruption are a patient with hypertension, a patient who, for one reason or another, be it recreational or medicinal, has been exposed to vasoactive drugs. So we have a couple of vasoactive drugs that we can give. And then there's a whole laundry list of vasoactive drugs that people can buy on their own. Some other things are preeclampsia. We'll go into that pretty good in detail here in just a couple minutes. Multiparity, so multiple pregnancies or multiple births. A previous abruption, a patient who smokes. And the last two are a shortened umbilical cord or a patient with a history of diabetes. So start thinking about some of these things and you'll start putting the pieces together that A patient who is pregnant, who is already more healthy and making good lifestyle and good life choices, is very much more likely to have a normal pregnancy. Thankfully, for the most part, most people, when they are pregnant, they take really good care of themselves. They receive that prenatal care, and a lot of these problems are fairly well avoided. If you're assessing your patient and you ask about prenatal care and how far along, and when was the last time you saw your doctor, when was the last time you had an ultrasound, and these answers are difficult for them to come up with, or they say they haven't received any prenatal care, that should heighten your index of suspicion that something could be going on here. Something's looming, and be on your toes. And one of the big things we're going to talk about is hemorrhage. We're going to talk about significant bleeding, because that's something we will be able to put our finger on right there and say, all right, I found problem A. The rest of the stuff, there's not a whole lot we can do with it. But I can realize that my patient has some pretty significant vasculature down that way, and we need to be on about the business of getting them to the emergency room, so that if that vasculature is leaking for any reason, we can get it fixed. Ruptured uterus is just what it sounds like. The muscular structure of the uterus actually will tear. The uterine wall really becomes very, very thin, especially around the cervix, as the uterus gets bigger and bigger. We can have spontaneous rupture. That can just mean that it happened all on its own for no real apparent reason, or it can be as the result of trauma. But what happens is, when that rupture occurs, the fetus is actually released into the abdominal cavity. So remember, there's no real dividing line between the pelvis and the organs in the pelvis and the actual abdominal cavity. Mortality of the mother for a uterine rupture is somewhere between 5 and 20%. Infant mortality is about 50%. Uterine rupture is an immediate surgical need. This patient needs to be operated on first to get the baby out, because there's nothing else they can do until they get the baby moved, and then they have to repair the tear. If a patient has had this previously, so any of these problems, uterine rupture, abruptio, previa, if they've had this before, it's a very good indicator that they'll have it again. And the same thing rings true for any of the other prepartum or antepartum problems that we're talking about here. So, previous uterine rupture, history of abdominal trauma, history of a very large baby, history of multiple births, a prolonged or difficult labor. If the patient has had a C-section or any uterine surgery previously, there's going to be a weak spot in the uterine wall, and that weak spot is suspect when it comes time for the uterus to start doing its thing and pushing that baby out. And we do worry about some possible uterine rupture. What we're looking for as far as signs and symptoms is a tearing or shearing pain in the abdomen. Could be constant and severe. We're thinking nausea, signs and symptoms of shock. Could be some minor vaginal bleeding, most likely, but it also could be pretty heavy. We may have a complete cessation of uterine contractions, or the most indicative, we may actually be able to palpate the baby in the abdominal cavity. So if mom has been struggling to deliver this baby, and then all of a sudden the uterine contractions go away and something has changed and we have tearing pain, we know that we are absolutely on the clock. Signs and symptoms of shock should always be cause for concern, whether your patient is just delivered or 1,000 years old or anything in between. We are always going to be on the lookout and treat aggressively with signs and symptoms of shock. So keep them warm, oxygenate, rapid transport, put them on that left side position so that the baby isn't causing even more blood flow problems. Ectopic pregnancy. Now, I talked about this briefly yesterday, and I want somebody to teach me about ectopic pregnancy. What did I say yesterday when we were talking about this?
It's a real for life or emergency.
All right, I'll take it. It is a real for life emergency. This is when that embryo is fertilized and implanted in the fallopian tube rather than in the uterus. Now, if we take a quick peek at that fallopian tube and compare it to the uterus, we will see fallopian tube, very, very little. Uterus, really a whole lot bigger and meant to do the job of growing a baby. 90% of ectopic pregnancies happen this way, and it can cause a rupture of the fallopian tube. It can cause pretty significant bleeding. Some of our assessment findings may be dull, achy kind of pain that's kind of poorly localized initially from sort of all the inflammation and aggravation in that area, and then a knife-like abdominal pain when things really get bad in one of the lower quadrants, either right or left, because there is a fallopian tube and an ovary attached to both the lower parts of both lower quadrants. There may be some light or heavy vaginal bleeding. There may be none at all. Generally, if we think lower abdominal pain that radiates to one or both shoulders and some changes to my patient's vital signs, we start to maybe even later on after the rupture has occurred, really like late sort of sign would be some discoloration around my patient's umbilicus. Why would I see some color changing around my patient's belly button?
Hemorrhaging?
Yeah, bleeding internally. We're starting to develop a bruise, and that takes a little bit of time. Patient may have an extreme urge to defecate, so they may really feel the need to move their bowels. That is also going to be a normal finding in a patient who's not describing all of these sort of pain signs and symptoms. Generally, when a pregnant woman who you're about to make a field delivery with says, "I need to go to the bathroom," don't let them go. Don't let them leave you, because you will be delivering toilet baby, and nobody wants to deliver toilet baby. We'll talk about regular, average, everyday, run-of-the-mill baby delivery here in just a couple minutes. We got a few more ruddy, kind of awful things to talk about. So when I took my National Registry exam, and keep this in mind when you're studying and preparing later on today and throughout the rest, I felt like I got every single OB and labor and delivery question in the book, and a lot of them had to do with this. Seizures during pregnancy, let's call it for what it is, can be life-threatening for mom, absolutely life-threatening for the fetus. We're going to treat these the same as any other seizure patient. We want to protect them from injury as much as possible. We go right back to that transport on the left side. We're going to oxygenate. But the next couple things we're going to talk about are big topics, as far as I'm concerned, for the National Registry of EMTs, and that is preeclampsia versus eclampsia. About 1 in 20 pregnant women are preeclamptic. Preeclampsia is mostly occurring in the last trimester, so months 7 through 9, most likely to affect women in their 20s who are with their first pregnancy. If your patient has a history of diabetes, heart disease, kidney problems, or high blood pressure, so diabetes, heart disease, kidney problems, or high blood pressure, they are at risk for developing preeclampsia. Preeclampsia is just that. It is normally characterized by some pretty significant blood pressure issues with mom. She'll be hypertensive, and she will have some other signs and symptoms to go along with that. We will see a lot of like swelling and bloating to go along with that. You know, you'll have a patient who maybe complains about things like jewelry not fitting anymore. But really what we're looking for is a blood pressure of more than 140/90. We consider that to be significant. A patient may complain of some sudden weight gain or blurred vision, swelling of the face, fingers, legs, or feet. We're talking like significant swelling here. And when preeclampsia turns into eclampsia is when mom has a seizure. This will, when it is going to become eclampsia and known as your patient is eclamptic, they will be seizing. That is the dividing line. They have absolutely no idea the cause of preeclampsia or eclampsia. Just know that it's characterized by hypertension and lots of swelling, and it changes from preeclampsia to eclampsia when mom has a seizure. Be on the lookout for this and treat aggressively, oxygenate as early as you can, and don't allow the patient to really hurt themselves any. Pregnancy-induced hypertension is common. Again, the 140/90 is what we're looking at as far as a blood pressure. The actual measurement of it is generally 2 or more occasions 6 hours apart. There's some other lab work type tests that go along with that, but your patient will probably know that they have been hypertensive throughout their pregnancy. And hypertension with an unrecognized seizure, so a patient who doesn't have a seizure disorder happens to be pregnant and hypertensive. If it looks like a duck and it quacks like a duck, it's a duck. Supine hypotensive syndrome, we have talked about that at length here over and over again. This is, we are allowing baby to compress mom's inferior vena cava. And if that inferior vena cava is being compressed against her sacral spine and coccyx by the baby's head, blood from the lower portions of mom's body will not return to that right atria to fill the right ventricle, to be pumped out to the lungs, to be sent back to the left atria, to be sent to the left ventricle, to be pumped back out to the body. So we will start to see some obstruction. We will start to see some problems with mom's blood pressure. We're going to have a preload issue that is going to decrease cardiac output, and therefore it will decrease perfusion. Most of the time, this is going to be a complaint of lightheaded or dizzy when laying flat. We want to make sure that the patient does not get any worse than that, because if it gets any worse, now it's not going to just be lightheaded and dizzy, it's going to be hypotensive, tachycardic, pale, cool, diaphoretic. So our history includes, have you had any bleeding? But if it is akin to and sort of walking hand in hand off into the sunset with, when I lay flat, I feel like crap, prop the patient up on their side after you've gotten to the end and, all right, no cramping, no bleeding, no pain. I just lay down on my back and I don't feel so good. Prop the patient up a little and see if that helps recheck your vital signs. You've provided a treatment just by positioning this patient. So now let's talk normal labor and delivery. Anybody out there have kids? All right, so nobody's seen this before or had to do this before? All right, rock on. We're gonna see some stuff today. So in all of our ambulances, we will have a disposable obstetrics kit. It will have things like a bulb syringe. It will have all sorts of material for clamping and cutting the cord and retaining any pieces that come out, because anything that leaves mom during this process will be brought to the emergency room with us, period. If we happen to deliver the placenta as well, the placenta comes with you. You need to bring any products of conception to the emergency room and to the hospital. There's bags, there's anything and everything you can imagine, sterile draping. We want to be close by with this, but make sure that it doesn't get contaminated. So this is another one of those uphill, upwind scenarios. Make sure you keep this off of the floor where you'll be delivering this baby. The first stage of labor is dilation. Dilation begins with the onset of regular contractions and then ends with that full 10-centimeter dilation of the cervix. We won't be checking for that, but that is the technical end of the dilation stage. Generally, the dilation stage, our first stage of labor, can last anywhere from 8 to 10 hours. If mom has had a baby before, so this is not her first pregnancy, it could be much shorter than that. The dilation stage ends. So I know I told you guys we're not checking for, cervical dilation on these patients. For us, the dilation stage ends when contractions are 3 to 4 minutes apart and last 60 seconds or more and are very, very intense. So when contractions have become very close together and are beginning to almost last for that entire time that we're monitoring, this baby's getting ready to come out. This Braxton Hicks contractions that they mention up here is what used to be referred to as false labor. It's generally fairly painless, short duration, irregular contractions. So it's in an effort actually for the body to improve placental blood flow. Those muscles contracting will actually move some blood to the area. What we won't find is that they're regular, like what we're measuring when we talk of a patient who's got those 3 to 4 minute apart contractions that last a minute, 2, maybe more, and they're kind of fleeting. Generally, we're looking at Braxton Hicks contractions when they're irregular like that and after the 13th week of gestation. The second stage of labor, well, that's pretty easy. The second stage of labor is when the baby is expelled. The baby will now be moved from the uterus through the cervix down into the birth canal, and the baby will be delivered. Generally, the contractions get even closer together and even longer during this second stage. That uterus is a muscular organ, and then it's going to contract and really squeeze and push that baby out into the world. Contractions are generally 2 to 3 minutes apart, lasting 60 to 90 seconds. So again, we're creeping up. We have gotten to the point now where contractions are almost constant. Mom will complain of some considerable pressure in her rectum. This is the one where I told you may feel like just an undying urge to move their bowels. Be advised, it might just happen. Soon after that urge to defecate or an evacuation of mom's bowels, the baby's head will appear. That's called crowning. We'll actually be able to see the top of the baby's head in the birth canal. Once the baby's head has moved its way pretty much fully out, the next thing will be a shoulder. And right after that, the second shoulder. And then directly after that, the rest of baby. This is pretty quickly, once the head and shoulders are out, the baby follows in short order. Generally, they say that a first pregnancy, this can last 50 to 60 minutes. The whole process of expulsion. If this is a patient who has had multiple births previously it could be as short as anywhere between 15 to 30 minutes. So here we have crowning. The top of the baby's head is showing. As the baby's head is coming out, you want to put a little gentle back pressure on that. It is in an effort to stop what we call a precipitous delivery. That means baby comes out like he's launched from a rocket launcher. So a little bit of gentle pressure back on baby's head. Be careful to avoid the face or soft spots, those fontanelles. And you're just trying to make sure baby doesn't come out like greased lightning. Once the head is delivered, we're going to check around the neck to make sure that the umbilical cord isn't what they call a nuchal cord or wrapped around the baby's neck. If it is, use your finger like a hook and try and slide that cord over the baby's head and do what's called reducing the nuchal cord. If you cannot reduce a nuchal cord, we can, at this point, clamp and cut that cord, and we won't have to worry about the compression of the cord anymore. Compression of that umbilical cord still at this moment in time, since baby isn't out, is another real for life emergency type thing. If you have a nuchal cord, just take it easy. Gently try and reduce that cord and get it over the baby's head so that it is no longer being pinched, and things will go along smoothly from there, because the next thing that will come is the shoulders. Generally, we're going to go back one. The baby is kind of in this position here. You may need to just have a little bit of downward pressure to get those shoulders by mom's symphysis pubis. But babies at this point, they're coming, so don't sweat it. Once the shoulders are delivered, be prepared to support the baby with both hands. We never ever want to pull or apply any traction, so we're not playing tug of baby with mom. This is all moving the way that it's supposed to, so no need to panic. Now that we got the baby out, be advised they are slippery and covered in all sorts of oh my god. We want to keep that newborn level with the mom's body. We're not going to pick the baby up. We want all of that blood that is in that cord to get pumped into baby. It has got some great stuff in it as far as to help the baby develop now that they're out, and help their immune system, and really just help them be a much healthier child. So it is important to keep the baby level with mom's vagina until the cord stops pulsing. You'll actually be able to feel a pulse through the artery that runs through that umbilical cord. Once the cord has stopped pulsing, we're going to clamp and cut. Most important thing we can do for this baby while we're waiting for that cord to stop pulsing, most newborns require very, very little as far as intervention. We want to dry the baby and keep them warm. And when I say dry the baby, we're trying to stimulate this baby into doing things that babies need to do to survive. So we're going to use like a rough towel and sort of scruff them up a little bit while we're drying them off. And that will generally stimulate this baby to kick right into gear and go on about having a really good respiratory rate and a really good heart rate. And it will do wonders at making this baby a productive little neonate. Once we've stimulated them to start breathing, we want to wrap them up and keep them as warm as possible. I once had a labor and delivery nurse tell us that they would buy us lunch if we showed up with a warm and screaming baby. We're going to clamp and cut the umbilical cord. We're going to put one clamp about 6 inches from the baby, and then a second clamp about 4 inches closer to mom. So we're going to finish just under a foot away from the baby, and we're going to cut in the middle. When we get to things like the NICU and those kinds of settings, they can actually start IVs in in that umbilical cord. That's why we leave that 6 inches away from the baby. And last but not least, the game is over here when the placenta delivers. The placenta will appear just like the baby's head did. You will have some crowning, and your mom will still be feeling some contractions. Again, we're not playing tug of placenta with mom either. It will come out. Just hold on to it. We don't want it falling. This is going to go in a bio bag and be brought to the emergency room with you, because they need to check and make sure that all of the placenta has detached from mom's uterine wall and that there are no retained products of conception. If you need to oxygenate a baby, and we'll talk about some neonatal resuscitation here in just a couple of minutes, we don't put oxygen directly on these little neonates, these little babies, because the oxygen molecule is actually bigger than the vasculature in their eyes. So we will actually damage, if not blind, a baby by putting high flow, high concentration oxygen on them. We want to just use some blow by oxygen. Maybe that stimulates them enough. Maybe we use some blow by oxygen while sort of scruffing them up a little bit. And babies are pretty good at just coming to it. Again, it's another one of those, most of the time, it's just like, you turn them up, you wind them up and watch them go. And we don't run into a whole long ton of problems anymore just because of how good most prenatal care is. Like now, even if you don't have health insurance, prenatal care and prenatal vitamins and all of that stuff is free to you, because it should be. It's not the baby's fault that things have taken a bit of a downturn and people are out of work and it's hard for people to find jobs, and the beat goes on, da 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 da. But it is just really a matter of dollars and cents, because if we don't take care of babies well in utero, they wind up being even more costly to take care of them downstream and for the rest of their lives. So we will get into here in just a minute some of our assessment. I have a video that will actually show you live and in real time a baby being delivered, but it is an hour since we started. So we're going to take a break and we will come back for assessment and treatment here in, let's say, 12 minutes. And off we go. Time is running. All right, now we are going to talk field delivery. Is everybody back? Is anybody back?
Yep.
All right. So, field delivery of a newborn. First, we need to make some decisions. Are we going to transport or are we delivering this baby on scene? Realistically speaking, this is one of those assist versus administer times. We are not really delivering this baby. We are simply there to make sure this baby doesn't plop out onto the floor. Mom's doing all the work. We are assisting mom in this delivery. It is always best when possible to transport mom and get her to the hospital so that that's where the delivery can take place. However, if birth is what we call imminent, so we start to see things like crowning or contractions that are now very close together and very, very long, so 2 minutes apart, but last for a minute and a half. If the patient feels the urge to push or defecate, or on palpation the abdomen is very, very hard, we are going to consider this our triggers for imminent delivery. If delivery is imminent, it is better to deliver right where you find rather than begin transport. Babies come out, they're slippery. Secondly, this whole process is messy. And lastly, you don't have much room to work in the back of an ambulance. So if birth is imminent, we're going to deliver on scene. It is relatively simple. We're going to position our patient and create as much of a sterile field as we can. So don't have this baby on a carpet. Don't have this baby in mom and dad's bed. Try and position your patient somewhere like hardwood or tile or maybe the bathroom, which will be much easier for the family to clean. We're going to position the patient so that the sterile field that we've created with our sterile equipment from our OB kit is placed around the vaginal opening. We're trying to keep everything as aseptic as we can. We're going to monitor our patient for vomiting, so we want to make sure that the pain hasn't gotten mom to the point of vomiting all over the place, because that'll create some issues with our sterile field and mom's airway. We're going to assess for crowning. That means looking and seeing, do we see the baby's head? As the infant crowns, we're going to still put that gentle pressure to stop an explosive delivery. We're not going to push hard. It's just enough to slow things down a little bit. Don't push on the fontanelle. Don't push on the face. We're also going to put a little bit of gentle pressure with a bandage horizontally across the perineum. Sometimes it is common for traumatic tears of the perineum, and if we use that bandage and a little bit of pressure to go horizontally across it, aids it in stretching rather than tearing. If the amniotic sac that houses the baby has not ruptured yet, go ahead and rupture the membranes. We want to monitor for nuchal cord as the baby's coming out. If we find a nuchal cord that can't be reduced, we clamp and cut right away. If the nuchal cord can be reduced, we just deliver business as usual. This bottom bullet point here, we no longer routinely suction fluid out of these infants' airways. I know we saw that on CPR, and I want to go ahead and reinforce that right now. This is no longer a standard operating procedure. It's found that when infants are suctioned, generally it's done too aggressively and it causes bradycardia. And infants, especially neonates, being heart rate dependent, bradycardia is a very, very nefarious, very bad sign with a baby that has just been delivered. We're going to support that baby as the body is delivered. We're just going to dry, warm, and position the infant. So we keep it right at the level of the vagina until the cord stops pulsing. We're going to monitor the time. Our partner will be monitoring mom and reassessing mom. We're going to stimulate that baby by drying them up really, kind of aggressively. Don't, not anything crazy, but really give them a good scrubbing to stimulate them to breathe. Once that's all said and done, we clamp and cut the cord. We're going to keep that baby nice and warm. We're going to put baby up on mom's chest for as much skin-to-skin contact as we can have. If at all possible and mom is willing and baby is willing, we're going to encourage baby to nurse, because that will actually help release some hormones and tamper down any hemorrhage that we have. We're going to use our sterile sanitary pad to collect any bleeding from the vaginal opening after the placenta comes out. And we record time of delivery of the baby and the placenta, and we're going to transport and keep everybody nice and toasty warm. This is really the way it goes more often than not. If we have some persistent bleeding from mom, the nursing is going to be very, very important, and we're also going to massage the fundus. Fundal massage will actually stimulate more contraction and start to slow down some of that bleeding. So we're really kind of getting in there and providing some significant pressure to get that uterus to contract more and stop/slow down some of the bleeding. If we have some pretty significant hemorrhage from mom, we want to go ahead and make sure we're oxygenating her. Still looking out for a hypovolemic shock. You will still be able to palpate the uterus, so you'll be able to find where it is you're supposed to be applying this massage technique. And we're going to continue to reassess. We're going to monitor mom for signs and symptoms of shock, and if need be, we will continue that uterine massage during transport. This is soup to nuts, our normal presentation and our normal baby delivery. Now we do need to talk about some of the things that happen when all is going to hell in a handbasket. We are going to assess the exact same way. The assessment doesn't change. If I have taught you guys nothing else, it's that our assessment is done systematically, and it is done the exact same way all the time, maybe with some just additional questions or some things here and there. Some of the things we're looking for with an abnormal delivery is a presenting part other than the baby's head. So the head comes out, it's called crowning. Anything else is called, oh my God. If we have amniotic fluid coming out of mom that has an abnormal color or smell, this is normally sort of a clear type of fluid. We don't expect there to be any real smell, any significant real color to it. If we see those things, that is a sign of fetal distress. It means baby has actually, more likely than not, defecated in the amniotic sac because of that distress, and they've been floating around in that. Labor before 38 weeks is considered preterm. When they guesstimate how pregnant someone is, they can be off by as much as 2 weeks a lot of the times. So 38 weeks is considered to be full term, and then after 42 weeks is considered late. Generally, people don't get that far anymore because the baby just continues to get bigger the whole time, and it turns into a bit of a nightmare all around. Or we have recurrence of contractions after the infant is born. That can mean that there are multiple births and we're about to have another baby. Just because all the advances and everything with ultrasound, it doesn't mean that sometimes one's not hiding and there could be multiple births in there and nobody knew. Our emergency medical care is also not going to change a whole bunch. We are going to provide the best care possible for mom, which is immediate transport, oxygenate, monitor for signs and symptoms of shock and treat accordingly, and just continue to be on point and out in front of things before they present with mom. So treat aggressively. The best thing you can do for the baby is do the best things for mom. So some of the abnormal presentations we're going to talk about here are a prolapsed umbilical cord. So that means rather than the baby presenting first, the umbilical cord actually presents and pokes out from the birth canal. We want to instruct the patient not to push. We don't want any additional compression of that umbilical cord. So don't tell them not to push. I don't know why, and every time I see this, I say that I'm going to look it up and then I forget to. It says when the patient feels the urge to push, we're supposed to instruct them to pant like a dog. I guess it's supposed to help them not contract their abdominal muscles. I will have a much better answer as to why we're doing that in just a moment when you guys come in later. We want the patient on the stretcher in the knee to chest position. So knee to chest is pretty much on the stretcher on all fours with their knees drawn up as tightly close to them as they can. I used to have somewhere that I worked previously, we had a labor and delivery nurse come in and do this lecture, and we messed around with a mannequin on the stretcher for probably longer than I even care to think about. And it is possible to transport a patient in this knee to chest position on all fours with their face and head downward and their knees drawn up tightly and still secure them appropriately to the stretcher. It just takes a little bit of creative license. What we are not going to do is we are not going to attempt to push this cord back in. We are going to wrap this cord in a sterile, moist dressing. So use your saline and some of the sterile bandaging material you have and wrap that cord up. Try not to touch it as much as you can. And we actually now, this is one of the few times where we will actually insert our hand into our patient and attempt to push the baby's head up off of the umbilical cord. That is baby's lifeline. So we need to do what we need to do in order to get the pressure off of the umbilical cord. And that is one of the very few times we will have our sterile gloves on from the OB kit, and we will lift baby's head up and ensure that we still feel pulsing in that cord. Because if the cord is still pulsing, that means baby is still hopefully getting the oxygenated blood supply that they need. Next, we have breech births. Breech births generally can happen during a prolonged delivery. A lot of the times they're associated with a newborn. There's a risk of trauma to both mom and baby. And breech is just that. When any part of the baby is presenting, so now we at least have baby sticking out, but the part of baby that is sticking out is not the head. It is either generally the buttocks or the lower extremities. Our delivery attempt changes a little bit with a breech. Breech babies are pretty common. It's difficult to deliver in the field. It is absolutely not recommended to try and attempt delivery of this baby in the field, but babies come when babies are good and damn ready to come. So if you cannot get to the emergency room, one of the things we need to do is make sure that we are providing some ability for baby to breathe. Once their chest is no longer being compressed and has been delivered from the birth canal, babies will generally begin to start breathing on their own. So with a breech presentation like this, the chest will be out before the head, so the baby will not be able to breathe appropriately. So if you look at the bottom of this picture right here, we're going to form a V on the baby's cheekbones and use that to push a little gentle pressure up on the head as it's being delivered through the rest of the birth canal. And that will provide some space for the baby to actually be able to breathe. If this is unavoidable, we just need to make sure we are providing for airway and breathing of this baby and be prepared to have to use some of the more advanced things that we're going to talk about here in just a couple minutes. Next, we will have a limb presentation. Limb presentation, again, we're talking the common sense department here. If we have a singular limb actually poking out through the birth canal, this baby will not be delivered in the field. Do not attempt to deliver this baby. It will not go well. There will be no happy times at the end of that. Oxygenate mom, keep mom warm, put her again in that knee to chest position with her pelvis up and her head down. Don't touch the presenting limb. We don't want to offer any type of stimulation whatsoever. So we are going to just leave that alone and transport. Get moving. Multiple births is also a pretty common complication, shall we say. After the first baby comes out, if the abdomen is still continuing to be very, very large and distended, or contractions continue extremely strong after the first baby comes out, or begin again within about 10 minutes of the baby being delivered, start sort of thinking about the fact that you might be having another baby with this patient pretty quick here. 1/3 of deliveries of our second baby can be breached. It's just because there's not a whole lot of room. So expect a breech presentation if you have a second baby on the way. If the second baby is not delivered within 10 minutes, transport. Most of the time, babies that are multiples generally will have a lower birth weight and they may require some resuscitation. So hanging out and waiting is not in anybody's best interest whatsoever. But still with mom and baby, going to keep them warm. We're going to transport them, and mom gets oxygen, baby only gets oxygen as needed, because we're going to talk about some neonate resuscitation here in just a couple of moments. Meconium, I mentioned already. Meconium is staining of the amniotic fluid, sign of fetal distress. Generally means baby has gone to the rest facilities inside his amniotic sac or her amniotic sac. It's generally hand in hand with a difficult labor and fetal distress. It will cause the amniotic fluid to turn like a green, brown, yellowish color. It can also happen if the baby has had a hypoxic event, so baby, for one reason or another, wasn't getting an adequate supply of oxygen. Meconium aspiration can present a problem with, the baby developing a lung infection, but even still, the only time we are going to routinely suction an infant is if you have a BVM in your hand. We're not going to blow any of that fluid into their lungs. So we would suction prior to ventilation with a BVM. If you don't have a BVM ready to go, you should not be suctioning. And when we suction an infant, we are going to suction the mouth first and then the nose. The way infants are wired is my mouth is for eating, my nose is for breathing. So if we suction the nose first, they'll start breathing and aspirate all that fluid anyway. We're trying not to do that because we're going to need to ventilate, and we're already concerned about their respiratory status. So if you have to suction, we suction the mouth first and we suction the nose second. Then you ventilate with your BVM. For any of you that have never used one of those bulb syringes before that come in the OB kit, you squeeze the bulb of that syringe before you introduce it into your patient. And then when you put it into where you want to suction, you just let go and it sucks all the material out. So you don't put it in the airway first and then squeeze. You actually depress the bulb so that it's all sort of squished down. And then when you put it into where you're going to suction, you release your hand and the suction happens like magic. Premature infants generally will have a lower birth weight. This is an infant born before 38 weeks. They are more susceptible to hypothermia and respiratory issues. So stimulate, keep them warm, oxygenate by blow-by if you need to. Generally, they just appear thinner and sort of wrinkly. Their skin may be more reddened. You may see like a crease across their foot. It's just they haven't finished growing yet, so they haven't quite filled in. Work aggressively to avoid heat loss in this situation and really sort of get that baby stimulated up and wrap them securely and keep them warm. Post-term pregnancy, like I've said, is beyond 42 weeks. It is generally not really a thing anymore. After 42 weeks, the placenta begins to sort of decline and break down. The baby will become less oxygenated, receive less nutrients, there'll be less blood flow. There's definitely some problems with oxygen and nutrient delivery and hypoxia. The baby's skull will begin to harden in utero. So they don't really like to let this happen anymore. And it's really not a big problem for us as far as things we see a whole awful lot in the field. Precipitous delivery. Somebody tell me how we're going to make this not happen. How do we slow baby down so he doesn't come out of there like a ballistic missile?
Apply pressure when the mom is crowning.
Yeah, a little bit of gentle pressure. We're just giving a little bit of a push. Want to make sure we avoid those fontanelles. And from the rest of that, the delivery and the care of both mom and newborn are exactly the same. Next thing we'll talk about here is shoulder dystocia. Now, if you look at this picture right here, you can see that the anterior or front-facing shoulder of this baby is trapped behind mom's pubic bone. That is going to cause a turtle sign, is really what it's called. When mom gets the urge to push, she pushes, baby's head will come out maybe a significant amount. And then when mom stops pushing, baby's head sucks back in like a turtle going into its shell. This is the hallmark sign of shoulder dystocia. It may really come with some issues as far as cord entrapment, so compression on that cord. There could be some pretty significant brain damage or death if the baby's not gotten out right away. If the baby's not coming out and he's doing that turtle sign, we're not pulling. We're still not pulling. I don't know why. I don't know why on earth. I don't know who was doing this because it's on like every single other slide is don't pull, don't pull, don't pull. So don't pull. Transport immediately. We're going to have the mom pant like a dog again to reduce the pressure of the contractions. We want mom on the stretcher with her knees pulled way high up to her chest. This is called the McRoberts position, that pulling of the knees to the chest. This is actually going to move the symphysis pubis. It's going to pull her pelvis open more and open up the birth canal for hopefully this baby to come out. We are officially in a hurry. Oxygenate mom, keep mom warm, have her in this McRoberts position, and get on about your business. And the business is transport and make sure mom's not going into shock. We've talked preterm labor here and there. This is going to be premature labor. It's after 20 weeks, but before 37 weeks. So after 20 weeks of gestational age and up to and including the 37th week of gestational age, because after 38 weeks, we're considered full term. Preterm is the onset of labor. It does not generally always lead to birth if the labor can be stopped. What we're looking for here is history. If mom's telling us that she's not at least 38 weeks and she feels like she's in labor, as far as I'm concerned, this is preterm labor. Generally, preterm labor comes very much hand in hand with a whole bunch of abnormal presentations, because as the baby is getting ready to be delivered, it moves into that face down, head towards the cervix position so that it can be in position to be delivered when the time comes. We want to do our best to keep our patient calm. This is definitely a time where we would want an ALS backup. We are going to want to keep mom warm and oxygenate her. And this is another time where we are about the business of moving things. So move this patient to the closest appropriate facility and do not delay. Preterm labor can actually turn into premature rupture of membranes. So that means the amniotic sac has broken before the end of the 37th week. This is spontaneous. The onset of true labor has actually begun prior to the 37th week of gestation. It may not be a huge kind of crazy emergency like some of the stuff that we've talked about, but it is increased risk of infection for mom, and it is a lubricant to try and help move baby along. So this is a time where our premature rupture can turn into a premature baby pretty quickly. we can expect 500 milliliters or more of blood loss, so half a liter of blood from normal vaginal delivery. For one reason or another, the uterus during a significant postpartum hemorrhage has failed to regain its tone, and that has caused some significant hemorrhage. This is most common in patients who have had multiple births and delivery of a large baby. You know, the uterus gets stretched to the point where it has a difficult time returning and beginning to regain that the normal tone of the muscle. When we talk about how many babies and how many pregnancies, the terms we use are gravida and para. So gravida means how many times has your patient actually been pregnant? How many times has your female patient been gravid? And para means how many children do they have? So it is possible to see someone who's, you know, G2P1, meaning for one reason or another they had a pregnancy that did not go to term and did not end in a successful delivery. So gravida and para. Now we're going to talk care of our newborn. First and foremost, how many patients do we have now?
2.
2. How many ambulances should we have?
2 if we can.
2 for sure, because what I'm going to tell you next is going to be cause for all sorts of consternation. It is technically against protocol to transport this baby where everyone with any type of medical knowledge agrees baby should be. Baby should have skin-to-skin contact with mom, hopefully nursing, for the entirety of the amount of time that we are outside of the hospital. They should both be kept warm, and that is the way they should be transported. And now I'll tell you that it is 100% against protocol to transport baby that way. Why?
No way to secure the child in a,
No way to secure the child, and unsecured things in the back of an ambulance, especially in the event of a collision, turn into projectiles. I don't know for the life of me how you would be able to convince someone who just delivered a baby on the hardwood floor in their living room that they needed to be transported in a different ambulance than their child. Don't ask me for pointers because I don't agree with it and I don't have any advice for you. I have had people, I mean, we have 4 children. My wife has said I would take a cab. So there's your answer. I
it'd
don't
be
know
a fun conversation.
Oh my God, can you imagine the fight? Like all that plays through my head when I do this lecture is, and that's how the fight started. Because I mean, like most people, there's enough endorphins and there's enough adrenaline and enough epinephrine. Like a pregnant woman will whoop your ass over something like this for sure. And it just is. I understand why it can't be done, but I also would like to imagine that we could figure out a way to do it. You know what, bundle that baby up and 100-mile-an-hour tape the 2 of them together. I don't care what we have to do. Or how about just drive like a human on the way to the emergency room? You know, obey all posted speed limits and signs. But yeah, I don't. That's my soapbox moment for today because I don't know what to do in a situation like that. And hopefully I never wind up there because it would lead to me probably having to lie on paperwork, and that's always a bad idea. So let's talk about our care for a newborn. First of all, no, 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 no. We do not routinely do this. When do we suction a newborn? Come on, folks. Somebody tell me.
Not at all if we can help it.
Not at all if we can help it, but if we have to, when is the only time that it's really acceptable?
When there's like fluid in the airways?
Nope, not even then. I told you guys one very specific time when you should really,
Meconium?
nope, not even meconium. I have to be getting ready to do something else before I'm gonna do this.
Ventilate.
Yeah, if I'm not getting ready to ventilate, I have no business on earth introducing this bulb syringe into my neonate patient. The best things you can do as far as treatment for a neonate patient goes is stimulation and warming. Most of the time, they will almost immediately begin to do the things that a body needs to do in order to remain a viable human. It's really not a huge issue. But letting them get cold is going to present some pretty significant issues. So we are going to swaddle this baby up. There is another possible use for our Reynolds wrap that we keep in the ambulance. A little bit of plastic wrap never hurt anybody, but just make sure you're doing things within reason. If you can get this baby dry and get this baby in a fresh dry blanket after you've dried and stimulated and gotten everything squared away, and the back of your ambulance is nice and toasty warm, and it's not like a January day where it's 5 below with a wind chill, maybe we don't have to shrink wrap our baby. But if you think that it's going to be an issue, make sure that it isn't, because they don't have the energy stores at this point, and babies don't shiver. So cold just means this baby is going to be cold, and a cold baby is not a happy baby. So our assessment, this APGAR score, this is another thing that the National Registry absolutely loves to ask you all. APGAR is appearance, pulse, grimace, activity, and respirations. Appearance, when we look at this baby, what color is it? Is it cyanotic or pale all over? That would get a score of 0. Do we have some cyanosis in the hands and feet, but the rest of the baby towards the core is nice and pink? That gets 1 point. Or is the baby pink from stem to stern, and we can go ahead and give it 2 points. What I can tell you is most babies do not come out completely and totally pink. This is one of those spots where a 1 is pretty much okay, as long as it is not systemic cyanosis. We do have that, pink around the core and some cyanosis in the hands. That's all right. Next, we'll move down to pulse. If we have no pulse, all right, that's pretty easy. No pulse, no points. We have a heart rate that is under 100. We get 1 point. If the heart rate is over 100, we get 2 points. We want to see tachycardia in our infant. We want to have a nice rapid pulse. They're heart rate dependent for their perfusion. They don't have a lot of blood. They don't have very big lungs. They don't have a whole lot of stores. So our heart rate over 100 is very, very good with an infant. Next is grimace. Grimace is, are they having reflexive activity? Wow, tongue twister. Reflexive activity to stimulation. Do we have to actually do something to get them to move? That's 0 points. So it's almost like a response to painful stimuli, but we're not really inflicting pain. If they're kind of making that little baby kind of grimace face, they get 1 point. Or if I do something as I'm stimulating this baby, so I can be evaluating this as I'm scruffing this baby up and stimulating them with my towel. If it is making them cry and wail and cough and sneeze and make faces, they get 2 points. And then activity is, how much is this baby moving around? Is it totally limp like cooked spaghetti? That's 0 points. If They have some flexion, but no active movement. So some muscle strength, but they're not being the little wiggly worm that most babies typically are. That's 1 point. If they are actively moving and doing the things that babies do, they get 2 points. And then we get down to respiration. If they're not breathing, 0 points. Slow or irregular respiratory effort with a weak cry, they get 1 point. Good respirations, nice strong cry, so your typical screaming baby that we always see on TV when people deliver babies, that's 2 points. Infants don't generally come out scoring a 10 on this scale. As long as we have an infant that comes out and scores 7 points on this APGAR score, all they need is that routine care, some stimulation, and some warming. If they are slightly or moderately depressed, that's between 4 and 6 points. They really just need some more stimulation and maybe some blow-by oxygen. Now, if our neonate is 0 to 3 points, we're talking severe depression, and we're going to need some extensive care and most likely ventilation. We will get into all of that in just a moment. But let's get back to brass tacks here and say most infants just require the basics. Some mild stimulation, some temperature maintenance, maybe just a little bit of blow-by oxygen, and they will be just fine. We are looking for a respiratory rate way above 60, so the kid is breathing way too fast. Because what we're looking for is 30-ish to 40 breaths a minute for our neonate patient. So if they are breathing at 60 times a minute, or show me any signs of severe depression or distress, we have to do something. If their heart rate is well above 100 and we're getting to, 180 and weak pulses, this is pretty significant depression. The flip side of that, does anybody remember what my cutoff was for when I should supply compressions to a pediatric patient? It was a heart rate below something.
Was it below 80?
Close. It was below 60. So if they have a heart rate below 60 and signs of poor perfusion, which they will, we're going to start CPR. And that includes our, either 30 and 2 or 15 and 2 and bag valve ventilations. And we're really going to start working pretty significantly on this child. When we talk neonatal resuscitation, we always want to start as least invasive as possible. The smallest amount of treatment that I can give this child to have them turn the corner and get better is really what we're looking for. That's why it's an inverted pyramid. You'll look at the top here and you'll see that drying, warming, positioning, suctioning, some tactile stimulation, really all of this stuff is just aggravate the baby and try and get them to do the stuff that you want them to do. Realistically speaking, that's what we're going for. Just irritate them. If that doesn't work and we still have either a respiratory rate that's too fast or too slow, a heart rate that's way too fast or too slow, we're going to provide for them some blow-by oxygen and try and get that heart rate to come up and try and get that respiratory rate to come up. And if that doesn't work and we still aren't seeing the appearance, pulse, grimace, activity, and respirations come up to where we want them, we're going to switch to a BVM. When we provide BVM ventilations to a neonate, we're looking for around 40 to 60 breaths per minute with supplemental O2. And when all else fails and the heart rate is beginning to fall below 60 beats per minute, we are going to perform Neonatal resuscitation. Neonatal resuscitation is a bit different, really, when we sort of move on from the realm we're in right now. But what we're looking for is cardiac arrest management. So we're going to go ahead and supply our American Heart Association CPR because that's what our training is. Just realize that you may need to provide faster compressions and breathe for this patient a little bit faster. We're trying to now get them to the point of doing all of these things on their own. And we're trying to connect the heart rate dependent nature of a neonate. And we're also trying to correct the hypoxic problems. So you may be asked at some point to increase the rate of compression or the rate of ventilation, depending on what is found to be going on with the baby. And when all else fails, just take some solace in the fact that most of the time, all of this goes slick as slick can be. Anybody have any questions?
So it's kind of one of those, they've been doing this long before EMTs existed, so it's kind of.
Yeah, I mean, that's spot on. I mean, people have been delivering babies now for millennia. That's the only reason we all came to be about. So really, when we get right down to it, it kind of just happens on its own. And all we can do is be there, and we really are just straight assisting. There is not a whole bunch of us doing a lot that goes into delivering a baby, for real. All right, I am going to give you guys another short break before we trudge through the next lecture. We are not going to get to all three, and I'm trying to decide whether we're doing regular pediatrics or just the lifespan development with pediatrics mixed in. I have to figure out which one is more possible. So I'm going to give you guys a short 5-minute break, get up for a stretch and get some coffee. And when we come back, we'll finish up for today. Okay, everybody, we're back. We are going to go through chapter 7 now, lifespan development. This is not quite as long and involved as the obstetrics and neonatal chapter. This should take us pretty close to right up to time for us to break for lunch. I will post all of this, and I'm going to try and get through the pediatric emergencies lecture while you guys are at lunch, and I'll just record that and see what I can do about getting that posted online as well. But let's get rolling. Lifespan development.
Thank you for watching this video. My name is Brian Collin, and today's topic is Erik Erikson's theory of psychosocial development. Remember that the best way to study is to take practice tests. If you can't find practice tests, create your own using the Learn My Test study tool and learn while you do it, or search our growing list of test banks for one in your field of study. Sign up for free at www.learnmytest.com. Erik Erikson adopted the belief from Sigmund Freud that development is characterized by a series of stage-related conflicts between two perspectives. He believed that you must hold both perspectives in order to achieve identity strengths, which he defined as virtues. The first stage-related conflict in Erikson's theory is trust versus mistrust, and often occurs between 0 and 18 months. During this stage, an infant must depend on their parents or primary caretakers for basic things such as food, water, shelter, and emotional needs to survive. Children who can depend on their parents for these needs can trust or count on them, while those who can't may have difficulty trusting others now and later in development. Erickson believed that children who learn to trust their caretakers develop the virtue hope, where they view the world as a good place where people can be trusted. The second stage conflict of Erickson's theory is autonomy versus shame and doubt, and occurs from ages 2 to 4. During this stage, children learn to do activities on their own without the help of their parents. For example, children learn to go to the bathroom on their own or learn to dress themselves. Parents who get upset with their children doing these activities on their own may have children who struggle to be self-sufficient later on in their development. However, parents who let their children solve problems on their own when they are ready for them will have children who have the confidence to do things on their own later in development. Erickson defined the virtue for stage 2 as will, or the child's ability to express his or herself by doing things on their own. The third stage conflict in Erickson's theory is initiative versus guilt, and tends to occur between 5 and 8 years of age. During this stage, children take a step from spontaneously doing things on their own to setting goals and working toward them. Little Johnny may want to learn how to ride a bike because he wants to be able to ride down a big hill in his neighborhood. Erickson argued that many children in early childhood, like Johnny, engage in risky behaviors when they set goals. When Johnny tries to ride down the hill, falls on his bike, and gets hurt, he feels guilty that he did not successfully make it down the big hill without falling. He may go home and act aggressively toward his parents because he was unable to achieve his goal. Erickson argued that children in early childhood can often engage in aggressive behaviors toward their parents and others because they are upset with not reaching their goal. He defined the important virtue of this stage as purpose, or having a goal or reason for performing certain behaviors. The fourth stage conflict in Erickson's theory is industry versus inferiority, and occurs from ages 9 to 12. During this stage, children are more receptive to feedback from adults about their competence and begin comparing their achievement and abilities to peers. For example, children learn whether they are more attractive, a better athlete, or a more superior student than the other children in the class. They may discover things that they are good at and should pursue as a hobby. Children who receive negative feedback from adults compared to other children may view themselves as less competent, which may lead them to have a negative view about their ability and not set challenging goals that require them to perform their best. However, children who receive positive feedback from adults in comparison to peers tend to have confidence they need to pursue goals that they need to be successful later in their development. The fifth stage in Erickson's theory is identity versus role confusion. And Erickson believed that it occurs from 13 to 19 years of age. However, Erickson did state that this stage is often prolonged. During this stage, adolescents are setting boundaries with parents, such as having their own private lives with friends and romantic interests. They are also searching for a place within adult society, which can include a search for an occupation, gender, political views, and religion. During this search, children may often experiment with different identities and viewpoints in order to find their true identity. The sixth stage of Erickson's theory is intimacy versus isolation, and occurs from ages 20 to 39. This stage involves finding a true romantic or intimate partner in contrast to living alone, aka isolation. As such, Erickson defined the virtue for this stage as love, because ultimately the stage involves finding love. The seventh stage of Erickson's theory is generativity versus stagnation, and occurs during ages 40 to 59. When thinking about this stage, think of generativity as generation, because Erickson defined generativity as giving back to the future generation. This can involve starting a family, raising children, caring for aging parents, contributing to society for your careers, and being a supportive friend and family member. The virtue of this stage is care, because Erickson believed that success in middle adulthood is about providing care to the important relationships in their lives, such as parents and children. As such, he believed that not having these important people to care for or not having the means to do so can lead an individual to feel non-productive or stagnant. The eighth and final stage of Erickson's theory is ego integrity versus despair, and occurs after age 60. In this stage, older adults look back on their life and reflect on whether they lived a happy and productive life. Adults who feel good about their experience in life tend to have a lot of experience to draw upon to help and support others in their life, which is why Erickson defined the virtue of this stage as wisdom. Older adults who are satisfied with their life tend to be happy, while others who felt like they didn't live the life that they wanted may feel sad and depressed. Now let's review Erickson's stages. Stage 1 is trust versus mistrust, and occurs from 0 to 18 months, 0 to 2 years, and the virtue for this stage is hope. Stage 2 is autonomy versus shame and doubt, and occurs often in ages 2 through 4, and the primary virtue is will. Stage 3 is initiative versus guilt, and occurs in ages 5 to 8. The primary virtue is purpose. Stage 4 is industry versus inferiority, and occurs during ages 9 to 12. The virtue for this stage is competence. Stage 5 is identity versus role confusion, and occurs between ages 13 and 19. The virtue for this stage is fidelity. Stage 6 is intimacy versus isolation, and occurs between ages 20 and 39. The virtue for this stage is love. Stage 7 is generativity versus stagnation, and occurs between ages 40 to 59. The virtue for this stage is care. The eighth and final stage is ego integrity versus despair, and occurs in ages 60 and up. The virtue for this stage is wisdom. Remember that the best way to study is to take practice tests, and if you can't find good practice tests, build your own and learn while you do it using the free Learn My Test study tool. You can also look in our growing list of test banks for one in your field of study. Thank you so much for watching this video. If you liked it, check out our other videos posted on our channel. Also, please hit the like button and subscribe to our channel to get updates on our new psychology videos as they come out. If there's anything you would like me to make a video on, please feel free to enter it in the comments.
All right, so human growth and development is really what we're talking about here. Humans grow and change and develop, and their minds change and the way they look at things change, as well as during our early formative years, our physical attributes change. And then as we get later in life, things as far as physical nature go also will change again. So we have to lump all of these things together when we start talking about how we're going to assess patients and what we can expect as far as normal reaction from them. And it may alter the way that we do things. Take it from right here. Neonates, infants, they develop and get larger and they get bigger and really grow and change. But it's not like we can ask them questions about their medical history. They aren't even old enough to really have a history. We have to assess based on what is normal for their age. Neonates are birth to 1 month, infant is 1 month to 1 year, and they are growing and changing on the daily. We talked about infants being heart rate dependent. The younger the person is, the faster the pulse and respirations are going to be. That is just a fact. Blood pressure will generally begin to start corresponding with increases in age. Neonates generally weigh 6 to 8 pounds at birth, and they can grow up to 30 grams. So that's somewhere in the neighborhood of 10% of their body weight every single day. When we have a neonate patient, we can expect a heart rate of anywhere from 90 to just under 180 and a respiratory rate of around 30 to 60. And then shortly after birth, we start to see those numbers come down. The heart rate settles in at around somewhere between 100 and 160. And our respiratory rate will stay somewhere between 25 and 50. And then as that patient gets a little bit older, we will see those numbers start to come down and slow down a little bit because they are getting bigger by almost 10% a day. Now they'll have more stores, they'll have a little bit more circulating blood volume, their lungs are beginning to get bigger. When a neonate first comes out, they switch from fetal to independent circulation. That fetal circulation is the blood not really being sent to the lungs for oxygenation because the lungs aren't available for oxygenation. It is oxygenated blood from mom being sent out into baby's systemic circulation at that point. They switch to that right as they come out. That is one of the first things that goes on, is they switch to that independent circulation and their hearts start pumping and things go along swimmingly from there. Children who are under 6 months are very prone to nasal congestion. That is an airway obstruction for an infant patient, because infants, mouths are for eating, noses are for breathing, and the two never cross. So an infant who has some significant nasal congestion really does have a bit of an airway issue. Infants have larger tongues, we know that proportionally. They have shorter and narrower airways, so airway obstruction is common. Their ribs are much less rigid, so their chests are more malleable and pliable. They also have, by surface area, a much larger head than adults. So when we are going to use some of our airway techniques, we want to put that infant in a sniffing position, that nice neutral position with something folded up between their shoulder blades to pull their airway open so that we can manage and ventilate as needed. The nervous system just continues to grow and continues to change. These reflexes are pretty well lined up right away. The second we start doing sort of a neuro assessment, this Moro reflex is when you startle an infant, everything just opens up wide. They open up their fingers, they open up their whole body, and they sort of almost appear to grasp at things. The palmar grasp, if you've ever been near a newly born baby or even just a young infant and you put your finger inside the palm of their hand, they close their hand on it, that's their palmar grasp. The rooting reflex is instinctive. When you touch an infant's cheek, they will actually instinctively turn their nose towards whatever side that you touched. And if you stroke their lips, so if you touch an infant's lips, they will start to suck as if they were getting ready to eat. These are all things that we expect to be intact and could be part of your neuro assessment of a neonate or an infant. We have the fontanelles on an infant's skull. These are the spaces between the individual bones of the skull that haven't fused together and become solid yet. We can evaluate these for things like signs of infection. If we see very, very bulge-like protrusions at these soft spots, we will say that we have a protruding fontanelle. And a lot of times that's either a sign of some significant head trauma, increased intracranial pressure, or infection. The flip side of that is it is a very useful tool looking at that for an infant that we think may be dehydrated. If increased intracranial pressure will cause those fontanelles to poke out like that, what do you think something like hypovolemic shock from non-hemorrhagic causes might look like with an infant's fontanelle?
Indentations?
Yeah, indentations. We'll have what's called sunken fontanelles. And we will see there's actually almost like a divot or a dimple where we expect, nice soft anyway, but it should be pretty uniform in what we're looking at. Infants, they don't have quite the fluid reserve, much like when we talk about any of the other reserves that we look for. And it can take only just a few hours of nausea, vomiting, diarrhea to actually cause a pretty significant hypovolemic shock in a patient of this age. Their immune system until the age of 6 months will really still be reliant on mom's immunity. Mom passes a whole bunch of her genetic coding onto this baby, and part of that is to protect the baby from disease. And that first 6 months, baby is pretty well protected by any immunities that mom has. They will also receive more antibodies from mom, bolstering their immune system if the baby is breastfed. The more things that a baby is exposed to, their psychosocial sort of network begins to change. At the age of 2 months, it is possible for a baby to recognize familiar faces. Babies are pretty easily passed around early on, but can be consoled by the faces that they see all the time. The further down we go into, infanthood, the more actual psychosocial behavior we can get ready to actually see. The younger they are, crying is the main method of communication. They begin to bond to stable, all the time people in their environment. As they get a little bit older, you can have some of that separation anxiety. So they get nervous not being around the people that are their general caregivers. Really, like that video was saying, trust and mistrust involves their needs being met. If you are meeting the needs of an infant, you have earned their trust. If you are not, they begin to fall towards that mistrust category. Moving right along from our infants, we have now entered the toddler stage. 1 to 3 years is considered toddlers and preschoolers. Their pulse is round about 90 to 150 beats a minute, so still can be pretty fast. Respiratory rate is somewhere around 20 to 30, and systolic blood pressure is right around 80 to 100. Capillary refill is still going to be a much better determinant of this patient's perfusion status, but do know that the systolic for anyone up to the age of 3 should be around 80 to 100. Moving right along, we're getting to preschoolers, 3 to 6. Pulse 80 to 140, so still pretty quick. Respiratory rate is beginning to slow some. Their lungs and their respiratory system is beginning to get a bit larger, and we will see their respiratory drive and their respiratory needs really start to come down a little bit. Blood pressure still maintaining around that 80 to 100 mark. They do not still yet have sort of the same muscular status as adults do. So they do not have the same development in their chest cavity and all of the musculature of breathing. Kids, a lot of the times we will see, a rapid respiratory rate when they're in some sort of distress. But since they don't have the musculature, those rapid respirations for an extended period of time begin to make them progressively more and more tired. And that will lead to some of like the head bobbing we'll see in a pediatric patient who's, if not already there, well on their way to respiratory failure. That passive immunity that they gain from mom begins to become lost. This is a lot of the times when vaccinations are becoming really important, especially as they're going off to school and being exposed to more of the germ factories like themselves. Neuromuscular growth just runs like crazy at this point. Kids grow like weeds. And they say average age to complete toilet training is 28 months, so just over 2 years. Preschoolers, they're psychosocial. They begin to speak and express themselves. Boy, don't they. The terrible 2s, 3s, 4s, 5s, and 6s sometimes. They begin to master basic language. They can talk. They can use simple sentences. They are beginning to become more social creatures and hanging out with other kids and playing games. They can understand cause and effect. They understand basic, basic if I do this, then this type of thing. Moving right along, we're now getting to the school-age children. Their vital signs are beginning to change quite significantly in this age group. They are getting much, much closer to be what we would consider reasonable and within normal limits for an adult. We don't see those heart rates of over 150 anymore. We don't see those respiratory rates being crazy, crazy high. Blood pressure begins to climb yearly pretty much for every year between 6 and 12, getting up to now almost 110 on the systolic side, which we would consider pretty close to normal for an adult. This is when kids start going through their biggest growth and development. They can put on up to or more 4 pounds or more and 2.5 inches every year. They start developing into puberty towards the end of this. Their baby teeth will fall out and their permanent teeth will come in. We will see an increase in brain activity all throughout. They are learning new things on the regular, and they are developing their personality and really sort of becoming almost like adolescents and then teenagers from there on. They can really try to figure out the good versus bad at this point, and they try to act to avoid being on the naughty list, right? This is, everybody's Santa Claus. If they know that there's punishment to come along with doing things that are wrong, they really start at this point looking for approval from friends, approval from family, adults, teachers. They start to make decisions based on what their premise of right and wrong is, and they start to develop either a concept of themselves and their self-esteem and self-worth, or on the negative side of that. So this is the age that is most malleable into making a good adolescent, and from there into a decently functioning adult. Adolescents 12 to 18, vital signs now reach the point where we start looking at them almost at the same of an adult. Respirations are right what we would expect. Heart rate is right what we would expect. And blood pressure is still going to continue to go up in little bits here and there until we reach adulthood. But 90 to 100 is still plenty amount of blood pressure to supply perfusion. So we are looking good as far as that goes. Generally, there's a 2 to 3 year growth spurt during the teenage years. Girls generally stop growing around the age of 16, boys around the 18. We'll start to see now reproductive changes. Girls will begin menstruation and start having their monthly periods. This is the time when pregnancy can actually become a thing. Voices will start to change. We'll start to see breast development in girls. We'll start to see people becoming more hairy. From there, we get into some of the psychosocial. Adolescents, teenagers, and their families often deal with conflict together, but adolescents and teenagers really are becoming their own person and want things like their own privacy. They start to be more self-conscious, so they will look more at what people think of them. It may become a little difficult for them to sort of create their own identity. They get to the point where they don't really know what they're supposed to do and how they're supposed to do it and how they're supposed to act and how they're supposed to do this. And it is kind of a time of some pretty significant struggle or some strife for kids that are going through this kind of awkward stage. When we're talking between 14 and 16, that's when we see sometimes kids making bad decisions and getting into things like smoking, drug use, unprotected sex. We'll start to see the development of some eating disorders. A lot of this goes right back to caring so much about what their peers think of them that they make decisions that they normally wouldn't because they're just trying to fit in. They do start to develop sort of their own code of ethics. And it was one of those things that once it is developed, it is written in stone for the most part. You know, you don't just all of a sudden decide that something that you thought was right or wrong for your entire life is now either right or wrong, respectively. This being such an awkward stage between the ages of like 12 and 16 or 14 and 16 especially, is a age group that is at a higher risk for suicide and depression. Moving on to the adult years, this is when things begin to level off a little bit, so I'm told. Ages 19 to 40, vital signs don't change much. Between the ages of 19 and 25 is when we are functioning at our most peak condition. Life typically centers on work and family and stress. This is the time where people begin to go through that love period that they talked about in the video and start to propagate and have children and, you know, buy a house and a white picket fence and 2 cars and a dog. This is probably the most stable portion of our life. This is your heyday. Because the further on we go, we start getting towards middle age, and this is when things begin to break down just a wee bit. Hopefully, unless you have a pathologic condition, your vital signs will remain pretty much the same. But things start to wear out a little bit. We'll start to see some changes in vision and hearing. We start to see some diabetes and high blood pressure and weight problems. This is generally when cancer is diagnosed in people 41 to 60 or so. It is a much more prevalent disease in this age group. Taking care of yourself through 41 to 60 is going to be very, very important. Eating healthy, making sure you eat a balanced diet and get some exercise are integral parts of moving on, because it only continues to go progressively downhill once we get through our middle adults. Psychosocial changes, we're achieving all of our life goals. We're going to readjust some, and as we move a little bit further and a little bit deeper into this, we start thinking and preparing for our own children to leave the home. Normally, being that this is such a stable period in time, we have the emotional depth and the emotional capability to handle life's issues. We may not only be caring for our own children, this is the point in life where we start thinking about having to care for our own parents as well. And then we get into the dark times. I'm telling you, with the amount of times I've done this lecture and the amount of EMT classes I've taught, I'm not super looking forward to getting old. I mean, it does beat the alternative, but getting old seems like a drag. 61 years or older, we start to see some pretty significant breakdown. Things begin to wear out a lot faster than we can get them fixed. Life expectancy changes all the time, but right now it is around 78 years of age. Things begin to depend on how well we have taken care of ourselves in the beginning. Vital signs are going to depend on what our overall health and condition is, any other medical conditions now that we have started to rack up as the years drudged along, and any medications that we've taken or currently take. Hypertension is one of the big ones that as you get older, you become hypertensive because your vasculature gets that problem with being able to expand and contract appropriately. We start to see some arterial disease and arterial sclerosis, atherosclerosis, and we may be overcome at some point by multiple medical problems and significant medication needs. Since we have been alive for a long time at this point, the cardiovascular system is going to fall victim to that atherosclerosis. And we're going to have some problems with heart rate, cardiac output. The vascular system won't stretch the way that it's supposed to and contract the way that it's supposed to because of this stiffness. We don't actually replace blood quite as rapidly, and as those blood cells decline and die off, so does our blood volume. We will be maybe even a touch hypovolemic at usual. Our airway is going to increase in size. The surface area of the alveoli, however, will decrease. The surface area of those alveoli is very, very important because that is what gives us the most possibility for gas exchange. So that decrease in surface area means that, we may actually start to become a little hypoxic because we're having some natural elasticity loss. Breathing becomes a lot more work. Aspiration or airway obstruction becomes a bit more likely. Since the surface area has decreased, that vital capacity, that space that is available for gas exchange, actually decreases, and the residual volume, the amount of gas left, because we're starting to now lose some muscular function and some elasticity, will actually go up. When we get into the endocrine system, we'll see insulin production begin to drop off. We've, at this point, sort of outlived the life expectancy of our pancreas, and that insulin production dropping off may stimulate us into type 2 diabetes. Our metabolism is going to go down. The physical activity goes down, so there is less food intake, maybe no food intake. This is why Nana is never hungry. It's also why Nana never wants to drink anything, because you add to that now some of the things we'll talk about in a minute with the digestive system, and you'll see why people just don't really, as they get older, have the same drive, have the same wants as people of a younger generation. Hormone production in both sexes begin to diminish, and sexual desire may actually start to fall off some. It never actually goes away though. Far as those GI changes, taste will change, saliva secretion decreases, so it's not as comfortable and nice to eat. It's not as much fun, it's not as much joy. The intestines don't move food along. That peristalsis begins to slow down. So food's not getting moved towards the exit quite as much. So constipation and things of that nature make it, again, less joyful to actually want to have something to eat. Our renal system begins to start to fail off. Kidney mass will go down by about 20% from the age of 20 to 90 years old. Kidney filtration actually decreases by about 50% throughout those years. The body doesn't have quite the same ability to conserve fluids as needed because of that loss of kidney function. Now add to that some of the medicines that elderly people take, and they make them go to the bathroom more. So now people, not only do they not want to eat because it's uncomfortable, they don't want to have anything to drink because it's uncomfortable, because I take my water pill and it makes me pee all the time. Moving on down the line of lists of reasons that it sounds miserable to get old, the nervous system begins to change some. Some of this neural network begins to slow down. Neurons in the brain are actually lost. Sleep patterns will change. So that's why a lot of the times old people, they go for the blue plate special and they're in bed by 6 o'clock and they're up at 2:30 in the morning. Those sleep patterns are beginning to become disrupted a little bit. Sensation will diminish. That's why sometimes the older people will actually become injured and not even really realize that they have, because those sensory nerve patterns are no longer really functioning up to snuff. The brain will continue to get smaller and smaller. We will have changes to vision, changes to hearing. Most people, as they age, will require glasses and hearing aids. Hearing loss is 4 more times likely than vision loss, which is a bit of solace to me because I would much prefer to have a hard time hearing than not be able to see. And last but not least, when we talk about the old folks, psychosocial changes. Most people will still have a high functioning brain, so they will still be sharp as a tack up to 5 years or more before they pass away. So most people don't really lose their faculties as much as we think they do. 95% of elderly people will actually live at home, but they will live at home in limited fashion. They have difficulty based on, restricted income and the inability to really afford some things. So it may limit their access to healthcare and medications. I mean, especially here in the Northeast, with most of the places around here being heated by oil. The number of times I've heard somebody say, well, I had to make the decision whether to have heat in the house or be able to afford our pills, and we chose heat in the house and food over pills. Isolation and depression can really start to become a challenge. Add to that the fact that, the longer somebody lives and the older that they get, some of their friends have started to die off. Most of their family has started to die off. Some people have even buried children. So you start to think like they've gotten to the point where they are all alone. And this isolation and depression really is a legitimate thing amongst the elderly and should be treated as such.